So a little bit of a background to start with. There's a number of different and conflicting theories around the exact natural history and biological process behind tendinopathy. So tendinopathy is known to be a generic descriptor of the clinical conditions, both pain and symptomatic-wise and pathological characteristics associated with overuse in and around tendons. There are specific differences between a tendinosis, being pathology in the absence of inflammation, and a tendinitis being a process with an inflammatory component. And certainly in most tendinopathy in laboratory models, there doesn't appear to be a great degree of inflammation. That plays a role in the initiation phase, but certainly not in the chronic phase. At histological examination, they have an increased rate of matrix remodeling, leading to a mechanically far less stable tendon that is more susceptible to ongoing. You get intracellular abnormalities in the tenocytes, a disruption of the collagen fibers, and an increase in the non-collagenous matrix. There are certainly different competing theories, as I said, to explain the pathogenesis at specific stages. And there's an abundance of therapeutic options, some in relation to each of these conflicting theories and often conflicting with each other. There's very, very few randomized prospective controlled trials, as we'll see in the table put together at the end. And it's important to note that what may appear clinically as an acute process or acute tendinopathy is actually the last straw, so to speak, or a well-advanced failure of what's been a chronic healing response that has failed. Based on this and the fact that there is histologically not a great inflammatory component involved, the literature certainly suggests that there's no rational basis for the use of NSAIDs. So this paper specifically goes on to discuss a whole menagerie of non-operative management options as well as operative management options, as well as discussing a little bit of the rationale and evidence behind it. We start with looking at the non-operative options. They are eccentric exercises, extracorporeal shockwave therapy, and a whole host of injectable substances, each with a different working through each of these in turn. Start with eccentric exercises. These are intended to promote, if we start firstly, eccentric exercises are the concept of activating a muscle while it is being elongated out against a force, rather than contraction being used to contract the muscle up. If we look at it from a biceps model, then we're looking at applying a resistive force and then having the muscle resist that force. This promotes structural adaptation of the muscular tendinous units, and the theory is that this then protects against increased stresses going through the muscles. Promotes collagen fiber crosslink formation and hence remodeling. That being said, this hasn't been demonstrated in histological models. There is no real mechanism at a histological level of why pain relief would be demonstrated, though most results in studies are, of course, they produce and reproduce pain, meaning that you actually get an element of progressive pain, which is the reason why pain relief occurs. And Doppler ultrasound does demonstrate decreased neovascularization following intervention. I'm not sure, I think I do mention it later on. A lot of the concepts surrounding tendinopathy look at the theory of neovascularization being ingrowth of vascularity and vessels into an area in a tendon surrounding the tendon, and these are accompanied by nerve formation and nerve growth. These nerves being responsible for the pain response. A lot of treatments actually look at the process of destroying the vascularity and thereby destroying the associated nerves. With regard to eccentric exercises, excellent clinical results have been shown in both athletic and sedentary patients, but certainly other studies do not demonstrate as much. Certainly more recent papers look at combining these exercises with shockwave therapy, which we'll get to in a moment, which is more effective than performing either. The extracorporeal shockwave therapy uses high pressure amplitude, very short rise times and short life cycle, high frequency, to create a pressure wave through the affected area, which in turn is supposed to stimulate soft tissue healing, and as well as inhibition of pain receptors. There's different papers, some looking at repetitive low energy treatments, being treatment weekly for a number of weeks, some looking at a single high energy treatment which requires either general or low tolerated. And certainly low energy therapy has been compared in multiple studies to eccentric loading and in addition to eccentric loading. It has similar success rates when compared, but when combined it does actually have greater success than using eccentric loading. In the table at the end we'll look at the numbers in some of these studies or meta-analysis yet around this. So then we move on to our injectable treatments. The first category of these is your high volume injections. As we discussed, neovascularization is a characteristic feature of tendinopathy, and this is accompanied by nerve ingrowth. Injection of a high volume of substance, and arguably any substance, causes destruction of these blood vessels, and hence destroys or interrupts the blood supply to the accompanying nerves. So high volumes of injection of normal saline, corticosteroid and anaesthetic, mostly in combination in a lot of the studies that actually does reduce pain, improves short and long-term function with patients with Achilles and patella tendinopathy. Interestingly enough, none of the papers pointed to look at any of the rotator cuff pathology, most Achilles tendon, patella tendon, or lateral epicondylitis. Injection of particularly normal saline is relatively safe and inexpensive. Corticosteroids have been added primarily to prevent the acute mechanical inflammatory response to the injection itself and the resulting trauma caused. And certainly we need to point out that this is an injection of corticosteroid and anaesthetic into the area surrounding the tendon, not into the body of itself, which, while proposed as a treatment, has also been associated with interestingly enough, the authors in this paper do make a comment not advocating corticosteroid injection, but all of the papers that are referenced are either prospective case series or randomized controlled trials looking at the injection of these substances, usually with a bupivacaine component as the anesthetic, as the method of choice. I'm not quite sure what they're basing their rationale. In terms of landmarks, ultrasound is often used to find the exact area and certainly to avoid injecting into the tendinous body. For the Achilles tendon, this is the Kager's triangle that one can see on an X-ray, being the lucency between the Achilles tendon, the calcaneum, and the Hoffer body when one's injected. Moving on to some of the more recent developments in treatment. The first of these is your platelet-rich plasma. Platelet-rich plasma is a bioactive component of whole blood. Essentially, it's an autologous blood donation, so blood is harvested from the patient at the time of procedure, spun off usually within the operating theatre, and then re-injected into the area of interest. And the rationale of this is it aids the regeneration of tissue with a very poor healing potential. It's been proposed since the 1980s for all sorts of different uses in orthopedics. Initially, a lot of the use was around augmentation of bone grafting, but there's still no definitive evidence that it does indeed improve bone. The rationale is that it does these release cytokines, being from your dense granules, as listed there, and the alpha granules, bind to receptors on the surface of local and circulating cells, and introduce an intracellular signaling process. This results in the production of proteins responsible for chemocellular axis, and then your matrix synthesis and proliferation. This all being said, there's emerging evidence now that in well-controlled trials that there is no difference in plasma-injected tendons versus I think it was an elbow one. Yeah. Next is injection of autologous blood, which has a similar theories behind it. Mainly your growth factor B and fibroblast growth response are the main reasons that healing is thought to be induced. You get collagen regeneration. It's interesting that they talk about as the rationale being a stimulation of well-ordered angiogenic response, particularly when a lot of other treatments say that you're actually trying to inhibit and destroy angiogenic. But there's a lack of experimental model for tendinopathy, so all the laboratory studies have been done on usually rat tendons, and these have been either normal tendons to start with or tendons damaged surgically. Process equivalent to that. Often this is done in conjunction with needling. The next treatment, which does have almost the reverse evidence sort of rationale, is that for polydocanol. We know that injecting local anaesthetic into the area of neovascularization occurring in the region of a tendon does relieve pain, perhaps proving that the pain response is coming from that paratendinous region, not from the tendon itself. Again, we're looking at the rationale of knocking off the vessels and hence the accompanying sclerosing substances such as polydocanol, which is a number of different brand names, can be used. And this has been shown in reasonably well constructed randomized controlled trials to show potential for reduction of tendon pain during activity. It has been shown in case reports at least to be associated with rupture of tendon, though not to the degree that intratendinous injection of Finally, for the injectable treatments, it does mention intratendinous corticosteroid injection, which is highly controversial. There's multiple case reports and complications in case series listed showing tendon rupture. There have been 3 equivalent in size randomized controlled trials, the first of which is done all the way back in 1988. 2 of them demonstrate a benefit, though do have quite different results, and one of them shows no benefit. A meta-analysis including these 3 studies concluded that there were certainly in animal studies it does show decreased tendon strength. Moving on to our operative treatment methods, and this section of the article starts by describing the general sort of principles of operative management of tendinopathy, then goes on to describe a number of slightly more complex interventions that can be. The objectives when it comes to treating a tendinopathy operatively is to excise fibrotic adhesions surrounding the tendon, remove the areas of failed healing, and restore vascularity, which again is an interesting objective in the context of sclerosing and multiple longitudinal tenotomies, whether done by ultrasound guidance or percutaneously or endoscopically or openly, have been shown to trigger neoangiogenesis. Treatments used. And the paper states that these are potentially indicated when conservative management of a tendinopathy has failed. There certainly needs to be an isolated tendinopathy with no involvement of paratenol. That being said, the study that described this doesn't really go into the best way to confirm. With a well-defined nodular lesion on ultrasound of less than 2.5 radiofrequency microtenotomy has also been described. This is considered safe and effective and induces acute degeneration or indeed ablation of the sensory nerve fibres. Then there are multiple other methods that have been described to destroy this neovascularity. These include electric regulation methods, minimally invasive stripping methods, and fancy methods described by endoscopy. And certainly there are a number of case series and case reports and descriptions in the literature of various methods of performing endoscopy on the posterior ankle region, giving you access to the Achilles, tib post tendons, the peronei, as well as posterior access to the ankle and subtalar joints, osteogonum, FHL, and deltoid ligament. As I said, this is described in a case series of 8 patients being the most thorough publication, and certainly this hasn't been controlled against any of them. So the rather simple algorithm that the article then goes on to describe, based on all this evidence, is that conservative non-operative management is tried in the first instance for a period of up to 12 weeks, looking at the use of eccentric exercises. Moving on to this, if there has been no responses, combining this with shockwave therapy, followed by the consideration for injection of any of the substances. The article does, beyond stating that corticosteroids are a poor choice, doesn't actually state with what evidence is being based for this. And then moving on after a failed response in 3 to 6 months to your operative management. The article itself does have a table, I'm told, which is an attachment in the JBJS sites. So this is based on all the papers that reference to. And certainly in all of these, we look that the evidence is not great for most of the treatments. All of the randomized controlled trials described have very small numbers. We're looking at 75 being the maximum number. There have been some limited meta-analysis done on injectable high-volume substances, as well as the injection of blood. But again, each of these are only as good as the series. Essentially, all of these focus on predominantly the Achilles tendon, followed closely by the patellar tendon and lateral. And there's unclear whether treatment or evidence for treatment differs between the groups. And based on that evidence there, I think that the algorithm that has been come up with probably fits for want of. Indeed, with neovascular destruction and endoscopy, I didn't even go through and list out the studies because most. So in conclusion, firstly, specific to the article then goes on to discuss the integration of biomaterials, potentially in the future, and the role of biological scaffolds and tissue engineered polymers, in addition to synthetic substances that can be used for tendon augmentation. It's unclear the article's rationale behind doing this because it's a far jump from the other treatments being described. It fails to then discuss any medical or pathophysiological rationale behind why these. From a more general context, certainly there is emerging evidence that there is a genetic component to tendinopathy, which, while not probably producing direct results in itself, could potentially point to the pathogen and make for more informed treatment options being described, and certainly a better understanding of the pathology is required. Highlighted when a lot of the treatments actually have. And certainly additional randomized controlled trials are needed to clarify the